Hi guys, this is Randy Kring, Emergency Ultrasound Fellow at Maine Medical Center. This is a primer on the Serratus anterior plane block, an ultrasound-guided plane block that improves rib fracture pain control. Rib fractures, as you know, are very common in the emergency department. We see them in 10% of all trauma patients, and 30% of patients with rib fractures develop complications, often relating to an impaired respiratory drive due to pain. And so aggressive pain control is essential for good outcome in these patients. We often turn to opioids to help with pain in patients with rib fractures. However, as I'm sure you're well aware, opioids have many adverse effects that are not desirable. Regional anesthesia, such as with the fascia iliaca compartment block, is of growing use in the emergency department for pain control that spares opioids. And for rib fractures, we look at the Serratus block as an equivalent sort of block. This block was first described in the anesthesia literature in 2013 by Blanco et al. And essentially, the indications for this block are as follows. These are for patients with anterior or lateral rib fractures 2 through 9, pain not controlled with Tylenol or ibuprofen. So if you have simply a mild discomfort, not necessarily an indication for doing this block, although of course it's up to the clinician's preference. It's important to note that this block is not effective for posterior rib fractures, and relative contraindications include overlying cellulitis, a patient with active bleeding along their chest wall, or a significantly elevated INR. We don't use a specific INR cutoff, but use your clinical judgment. And also the need for use of high volume anesthetic elsewhere, such as for large laceration repair or tube thoracostomy. Since we're using a large volume of anesthetic, we want to make sure that we don't give the patient too much. Think of this as a bridge to an epidural. So with bupivacaine or a long-lasting anesthetic, the block can last for 6 to 8 hours and be a bridge to an epidural in that sense. If you are doing this block as part of the Serratus anterior plane block study that we're doing at Maine Medical Center, the providers who are trained in performing the block for that study will know additional inclusion and exclusion criteria to take note of. So the supplies that you'll need to do this block, you'll of course need a ChloraPrep to clean the skin. We advocate doing raising a skin wheel of local anesthetic with lidocaine with a 10 cc syringe and a 25 gauge needle. And then for the block itself, this is a volume block, so you'll need a 30 milliliter syringe for the 30 milliliters of anesthetic solution you're going to instill in the chest wall. You can use really any needle that seems best for the habitus of the patient that you're doing the block on. I would advocate using an 18 gauge needle, just a regular length needle, owing to the fact that most patients, their body habitus allows you to reach the plane that you need to get into with just a regular length needle. If you have a very obese patient, using a spinal needle can be helpful. And then, as this is a plain block, we'll use a large volume of anesthetic. So a combination of 20 milliliters of bupivacaine, 0.5%, which is safe for patients who weigh greater than or equal to 50 kilograms, as well as 10 milliliters of normal saline to provide additional volume for this block. You'll also want the patient connected to the cardiac monitor and have access to intralipid in the case of a patient developing local anesthetic systemic toxicity. So being prepared for this is a good idea as we're using a large volume of anesthetic, although the incidence of local anesthetic systemic toxicity is thought to be very, very low. So the patient positioning and setup. So ideally, you'll have the patient in the lateral decubitus position, and this will allow you to identify the landmarks. So the serratus muscle is primarily what we're looking for, and you'll also note the pectoralis anteriorly and the latissimus dorsi inferiorly. You'll want to place the linear probe in a short axis orientation at approximately the mid-axillary line at the fourth intercostal space, kind of the same area where you would be placing a chest tube. And here is the anatomy as seen under ultrasound. So we have the pectoralis muscle anteriorly, the serratus just overlying the ribs, and the latissimus dorsi posteriorly. The nerve that we're going for is the thoracic intercostal nerve, which has branches that run above the serratus muscle. And so in an in-plane approach, you'll introduce your needle just above the serratus, and ideally in between the latissimus dorsi and the serratus is the best place to see the fascial plane. That said, as this diagram shows, the serratus is the muscle belly that lies above the rib. And so simply identifying, if you can't find the lat, simply identifying the serratus muscle as the muscle belly above the rib and the fascial plane on top of that will allow you to find the correct location. So here's a video clip of anesthetic being injected in the correct fascial plane. So in this case, we can see the latissimus dorsi and the serratus anterior and see those muscle planes being divided. This is an image from the group at Highland. Andrew Herring and his group made this excellent diagram showing kind of a little bit more zoomed out than that last image, where you can see the rib with shadow, the pleural line, and the serratus anterior muscle just on top of it. And so we're going to be going for the plane just above the serratus anterior muscle. So even if you can't see the latissimus dorsi, finding a rib, finding the muscle belly on top of the rib, and then going in the fascial plane above that, again staying far away from the pleural line, will be effective. And ideally, you'll have the patient in the lateral decubitus position. If the patient does not tolerate rolling towards one side or the other, then you can perform this block supine, as this image shows. It is a little bit less ideal because the anesthetic, we want really to go anteriorly to hit anterior rib fractures. And if you do the block with the patient supine, you're injecting the anesthetic in a more posterior distribution. That said, it's still thought to work and would still be effective. So again, identifying the serratus muscle sitting on top of the rib and the latissimus dorsi, and injecting anesthetic in the plane between the two. As with any ultrasound guided or nerve block, anytime you inject anesthetic into a patient, aspirating first before you inject to make sure you're not in a vessel is important. Unlike the fascia iliaca compartment block, which is injecting anesthetic into a deep space, with the serratus anterior plane block, oftentimes you're injecting a large volume of anesthetic fairly superficially, so it can be normal to see a large welt almost of fluid appear on the patient's chest wall, within the patient's chest wall rather, after you've injected. So don't be concerned if that happens. And this is a cadaver model where methylene blue is injected into the space, and you can see kind of how the anesthetic distributes and spreads. And so again, we're looking at anterior and lateral rib fractures 2 through 9. There is a decent number of case studies currently in the literature supporting the serratus anterior plane block. The largest case study published to date has 6 patients, so there is not robust evidence supporting the use of this block. However, the evidence continues to grow, and the existing evidence does support the use of this block. At Maine Medical Center, we are doing a research study on the effectiveness of this block, and just briefly outlining what we've found so far. So we're doing a prospective case series where we assess pain at rest, pain with incentive spirometry, and vital capacity of patients before the block, 15 minutes, and 60 minutes after the block is performed. We also record the morphine milligram equivalents received by the patients in the 8 hours after the block, and have assessed for complications in the 24 hours after the block. Our goal is to enroll 65 patients. To date, we've enrolled 7, and mean age of 72 years, 4 female, 3 are male. This graph shows the mean pain scores of our patients at rest and with incentive spirometry pre-block, 15 and 60 minutes after the block is performed. At rest, mean pain scores from pre-block to 60 minutes have decreased by 2.43, and with incentive spirometry by 1.43. Not enough to do a statistical analysis on yet, but trending in the right direction. Incentive spirometry performance is essentially unchanged across the groups, but looking at the morphine milligram equivalents and complications in our patients, the mean morphine milligram equivalent of 8.7 milligrams in the 8 hours after the block is performed is thought to be quite low, and we've had 0 complications in the patients we've enrolled so far. So to summarize, the serratus anterior plane block is straightforward, it's safe for patients, and can improve pain control in patients with rib fractures. Thank you for your attention, and I hope you consider doing this block on a patient that qualifies. Thank you.